All right, so good morning, good afternoon, everyone. Welcome to our monthly webinar series for Division 18 VA section. So really glad to be here with you all today. My name is, again, Edgar Villarreal, your VA section chair. We have really the pleasure of having Dr. Suzannah Creech join us today. So Suzannah, really appreciate you spending your time with us and for you to share your really important work in terms of how you support veterans and their families. So before we get started, just wanted to remind people that we are recording these webinars and that the webinar recording will be placed on our website as well, along with the presentation. We will be asking people to use the Q&A feature if you have any questions that you want to ask along the way. That way we can bring those to the attention of the presenter, or you can drop them in the chat. We will be monitoring the chat as well. In a little bit, I'm going to hand this over to Dr. Jeremy Sines, the chair of our Education and Training Committee, who really set up these webinars and the CEUs, and he'll provide you a little bit of a reminder in terms of how the CEUs work and some of the logistics behind that. So that being said, I wanted to hand it over to Dr. Sines. Again, thank you all for being here. We will give you all some other announcements at the end of the webinar in terms of upcoming webinars and our upcoming quarterly meeting for our VA section members. So stay tuned for those announcements as well. Thank you all for joining.
All right, well, thank you very much for the introduction. I think we have a wonderful presentation, but before we go into introducing Dr. Creech, just a couple of different reminders. With anything related to wanting continuing education credits, you have needed to pay for them ahead of time for registration, as well as if you're using a telephone number not associated with the Zoom, please make sure and email the webinar committee or the Division 18 VA section committee so that we can look at the number that you use and give you appropriate credit should you have been registered. And for non-members, paid. And for Division 18 members, no need to pay, but just so that we can see where you or what number you were using and confirm it. That being said, I have the pleasure of introducing Dr. Suzannah Creech, who's going to be presenting addressing the impact of PTSD on family functioning within organized healthcare. Dr. Suzannah Creech is a Ph.D., a research psychologist at the Central Texas VA and the VA Vision 17 Center of Excellence, or COE, and assistant dean for research and associate professor of psychiatry and behavioral sciences at the Dell Medical School of the University of Texas at Austin. She received her PhD in clinical psychology at Texas A&M and completed fellowships at the National Center for PTSD and the Brown Medical School Psychology Training Consortium. Her research program spans treatment development, clinical trial, and implementation science methodologies within organized healthcare settings. Her research focuses on improving family functioning and prevention of interpersonal violence, or IPV, its consequences in populations exposed to trauma, and her studies have been funded by the VA, DoD, and private foundations. And without further ado, Dr. Suzannah Creech.
Okay, well, thank you so much. And I'm so excited to be here today to present this work to all of you. And it's equally exciting to have friendly faces on this call, like my beloved mentor from internship, Lorraine Braswell, is here. I really appreciate you coming, and other colleagues like Sarah. And then, of course, Edgar and Jeremy have been close colleagues from the start of my work. So hopefully you can see the beginning of this presentation today. And I think, divisions like this division that is focused on public service, and many of us are working in organized healthcare settings. One of the things that I'd like to sort of leave as a takeaway is that while there can be great sacrifice that comes with working at some of the agencies that we work with, it's hard work, it's challenging to us, and it takes work to maintain our own well-being. There are also great strides that we can make because of the organizations that we work with and the ways that we can implement new clinical strategies. And so that's kind of an underpinning of this work that I'll talk to you about today, which is our work to implement the strength at home intervention across the VA. So I want to acknowledge our funders of this work, who have been many foundations like the Bob Woodruff Foundation, the VA, the DoD. I do have a conflict of interest in that I do receive book royalties from the APA for a book that we published about this work. And I'm obligated to tell you that I don't represent the VA in any of my discussions today or the government. And I also want to acknowledge all of the many partners, past and present, who make this work possible, especially our director, Dr. Taft, my mentor. He's really the developer of this program and our leader, and I have the great pleasure of working with him as the implementation and education director of our program. And we also work very closely with Dr. Leanne Bruce, the national program manager, and we've just had so many technicians and trainers work with us to make this program successful over the years. So another backdrop that I'd like to kind of have in your minds as you kind of digest some of the research that I'll share with you is that there's a statistic that it takes about 17 years on average for the knowledge that's gained in RCTs to be implemented into clinical practice. And something like only 14% of findings actually end up being implemented. And so that's a long time for these innovations to reach the patients that we want to help. And that's a really low number of implemented interventions. And I know many of you are familiar with best practices that we know about in the literature that just never see the light of day. Some of that is because they're hard and they're costly and there's a lot of barriers, but there are other barriers that can be surmounted through a supportive, organized healthcare system. And within this work that I'll talk to you about today, we're really focusing on the national problem and the impact of intimate partner violence. And so I want to share some of the language that I'll use throughout this presentation with you, so we're kind of on the same page. So it's really important that we're using trauma-informed and non-stigmatizing language when we talk about this problem. And so when I refer to IPV experience, that's persons who are experiencing IPV. In other work, you might see these persons referred to as victims. Sometimes they're referred to as survivors, but we really work to use the term IPV experience or persons experiencing IPV. And then same thing, the counterpart, persons using IPV or IPV use as the problem instead of perpetrators or batterers or abusers. Sometimes those terms are still used in the field, and you can imagine that someone that's seeking treatment for this problem, you don't really want to go to treatment for something for perpetrators or batterers, and some of that is driven by the court system, which I'll talk about in just a moment. The prevalence of IPV nationally is high, and its costs are similarly high. So in a person's lifetime, something like 36% of women and 33% of men experience contact sexual violence, physical violence, or stalking. If you look at just the proportion of persons who are experiencing that type of violence in the past year, it's about 5%. The numbers are really similar for the experience of psychological aggression from a partner in a person's lifetime. And of course, the cost is high. Both in physical impacts, mental health impacts, social and occupational impacts, with something like an estimated 3.6 trillion in lifetime survivor impacts. So it's really costly, these experiences. And in addition, using IPV is also costly. And we now have some predictors of what makes a person potentially more likely to use aggression in relationships. So one of the best studies of this is from an epidemiological study that's looking at psychiatric diagnoses and use of IPV in the past year. And in this study, in the past 12 months, really similar numbers, about 4% of men and 7% of women reported use of IPV. And what made it more likely to use IPV in a relationship were any psychiatric diagnosis. So that increases odds of using aggression by about 2.9 times. And when every diagnosis was compared along with other predictors, the only predictors that remained significant at the end of this very large study were younger age, alcohol use disorder, lower income, lower social support, and at that time, personality disorder. Other predictors that remained in the models when they lined these all up were the experience of child maltreatment and the experience of child and adult adversity or trauma. Those experiences led to a 2 to 3 times greater likelihood of using aggression in a relationship. And the number one predictor of using aggression in relationships was experience of aggression in relationships, which increased a person's likelihood of using IPV by 66 times. This large sample size study also showed that there were really no gender differences in these predictors in terms of what was associated with a person's use of IPV. Now, one of the reasons we're concerned about IPV in VA is not only its prevalence, which is high in our sample, in our veterans using VA care, but because we also have a high prevalence of PTSD in the veterans we care for. And PTSD is a strong predictor of use of IPV in relationships. And so in this study, it also showed that if a person had PTSD, they were 2.84 times more likely to use aggression in their relationship in the past year. This parallels results from other studies like meta-analyses that show a strong correlation between a PTSD diagnosis and use of physical or psychological IPV. Of course, now DSM-5 includes verbal and physical aggression towards other people as a symptom of PTSD. And one point, as I'm starting to talk about veterans, that I want to make is that rates of IPV in veterans are not different from rates in civilians when there's no PTSD present. And the implication that I'm making there, sometimes people will say, well, veterans are just more violent, right? IPV is higher in veterans because of their training or their backgrounds. And that's not really true. IPV is a problem across the country and the world, whether or not you're a veteran. Whether you're a veteran or not. But in our population and the veterans we care for at VA, there's an association with PTSD and use of aggression. And you saw earlier the association between the experience of childhood maltreatment and child and adult adversity or trauma. And so those are the folks that often come to us at VA. And those are significant correlates of aggression. And that's what we work on in our program. So when at the time when we started doing this research way back in 2008, there was no prior randomized clinical trial that had demonstrated an effect of an intervention on use of aggression in relationships. And studies had over and over shown that those who had received interventions in other settings averaged only about a 5% reduction in recidivism. And, you know, most people who come into contact with an intervention for use of aggression do so through the justice system. And in many cases, they're as part of some sort of judicial proceeding, they're mandated to a sort of state-approved program. And those are the programs that we're talking about here that really haven't been shown to be terribly effective past about this 5% reduction in recidivism. And so there's also very few other evidence-based interventions for persons at risk for IPV or indicated prevention. So that was sort of the scope of the field at that time when this work began. And some other concerns about what was out there, these sort of like state approved programs, is that they weren't tailored to military populations and they weren't trauma informed. And so remember, this is at a time where we're seeing this rapid increase in veterans coming into VA for treatment after their deployments. And so it was really important that we take a look at whether or not what was available was tailored to their needs. These state programs also, some of them will explicitly de-emphasize the role of psychiatric factors or things like head injury in aggression. They're typically held in large impersonal groups that have been criticized for not being grounded in empirical evidence or best practices. And so that led to our work with Strength at Home. My mentor, Dr. Taft, received funding back in 2008 to create a model program to address this issue. And so he created a 12-week group treatment to address IPV in veterans who had been using aggression in their relationship. And at the same time, created a 10-week couples group to prevent IPV. Most of this presentation today, I'll be talking about outcomes from the 12-week program for veterans using aggression, though I just want you to know that our couples program is also out there. Strength at Home has underpinnings in several areas, which is that it's cognitive, behavioral, and trauma-informed in nature. And it's focused on what we call our social information processing model of IPA in military populations. And so let me tell you a little bit more about what that is. So the social information processing model holds that trauma, the experience of trauma and its consequences like PTSD, lead to biases and deficits in social information. So these are things like how someone interprets an ambiguous relationship situation and the behaviors that they might choose in a difficult situation, for example. And laboratory studies have shown that social information processing mediates the association between PTSD and use of aggression. So these studies have found things like persons with higher exposure to trauma are more likely to interpret an ambiguous situation as threatening, for example. They've also found that people who use IPV are more likely to attribute more negative and hostile intentions to female partners, to have an emotional bias towards anger, and to select less socially competent responses to relationship challenges, i.e. to be more likely to use aggression, and to view aggression as something that yields positive results. So these have been shown in a number of laboratory studies. And let me just check the chat for a moment and see if we have any questions. Okay, great. So Strength at Home is for veterans or service members who've engaged in physical or psychological IPV. This is our veterans program that I mentioned. It's held in closed groups. And what that means is everybody starts and ends at the same time. That's part of the trauma-informed nature of the program, which is that if we want people to come and feel safe to talk about aggression in relationships, it doesn't really work if new people are coming in every week, right? So the sessions are 2 hours long, held over 12 weeks with 3 to 8 veterans per group. Initially, the preferred model was a male and a female co-therapist to sort of balance out potential gender roles. We've since dropped that. It was a barrier to implementation. It really wasn't ever supported by data. And so that's not really the implemented model at VA now. And the program also provides additional monitoring, treatment, and support. And so that monitoring might be symptoms. It's kind of tailored around whatever the veteran might need in terms of their care. Are they justice involved? Do they need housing, et cetera? Okay. The program also involves intimate partners. And so this is one of the things that can be, one of the more controversial or surprising aspects of our program, which is that our best practice is that intimate partners are contacted before the group begins and after it's completed. And they're offered the chance to make a safety plan with us, to receive hotline numbers, to be referred to mental health services and other support. And then we have a place where they can offer their perceptions of IPV in their relationships. We do this even if the couple has broken up. We view it as an ethical obligation to reach out to an affected partner who may have never come into contact with an opportunity to make a safety plan or a hotline number, and then sort of weighing this work in knowing that we're working with persons that may be using aggression, and that there's an affected partner out there somewhere. This is what we feel is the most ethical practice to sort of balance that issue and to make sure that we're providing the care that we need to. Nationally, it is considered a best practice in this area. Some other interventions that sort of feed into Strength at Home, if you're familiar with these, you'll notice CPT for PTSD and cognitive behavioral conjoint therapy for PTSD. Some of their elements are featured in our program. And then there's a prior IPV intervention that Chris Murphy had developed that informed some of the activities that we use as well. And so the stages of the program, remember, again, is over 12 weeks. So it starts out with psychoeducation, and I'll tell you a little bit more detail about each of these in a moment. And then once that psychoeducation stage is done, we do conflict management strategies, things like recognizing what is anger, what does that look like, coping strategies. And then finally, the highest level of the program is the communication skills training that we offer. And so in that psychoeducation phase, we do exercises that are highly influenced by motivational enhancement. So, for example, one exercise we do is the pros and cons of abuse. And so we have group members kind of get around a board and we write down all the things that they feel like have been pros of using aggression in relationships. And they'll say things like, my partner listened to me, or the argument stopped, or I got what I wanted, things like that. And then we have them list the cons of using aggression in relationships. So they'll list things like, I got a court case, or it was really scary. I lost my housing. I was hurt, those sorts of things. And then sort of at the end of that, we sort of have a conversation about, what does this look like when you see these written down? What if we could help you develop some new skills and understanding of yourself so that you can develop the relationship that you want to have without using aggression and without having those cons? Like, what if we can work on communication skills where your partner will listen to you, where you can express yourself? And so it becomes this motivational exercise that is designed to build into the next phase of the program. And so we help provide education about what is IPV and aggression, and how does trauma impact relationships? How is trauma related? And so a lot of times we find that people have a great understanding of what physical and sexual aggression are, but they don't really understand psychological aggression. And so we have some really rich conversations about, well, why might it be psychologically aggressive to throw your phone against the wall or to throw something at a person, for example? Why might it be aggressive to someone if you just left for hours and they didn't know where you were? What's the impact on the other person? We talk about core themes like trust, and we develop goals for the group. In the conflict management stage, we talk about all aspects of the anger response. So the physical, the thoughts that go around with it. What does it feel like? What does it manifest in behaviorally? We introduce self-monitoring of thoughts, feelings, and physiological responses. We teach assertiveness. We talk a lot about how passive responses to relationship situations can end up building and becoming blowing up into an aggressive response. And so what if we can teach you assertiveness, and what would that look like for you, and how do you do it? We teach timeouts for de-escalation. When we move to the coping strategies phase, we do anger-related thinking. We do realistic appraisals of threat through kind of looking at thoughts in threat situations. We do stress management. We do progressive muscle relaxation, which is a good session. And then finally, in communication skills, which you'll see is the back half of the treatment program, we focus really heavily on, well, how did you learn to communicate in relationships? What did your parents teach you about talking to a partner, how did you learn about emotions, for example? And they'll say it's a really tough session when they talk about some of the messages that they received both in their childhoods, and then again, unfortunately, many of these were amplified by their military training, where the only acceptable emotion was likely to be anger. We teach active listening, and we do role plays of all of these assertive messages, communication traps, where we look at scenarios and we talk aloud through those to look for patterns of problematic thinking that might lead to communication difficulties. And so now that you know what the program is, I'll start to tell you about some of the results of the program. So the very first study we did, and I was lucky enough to start this when I was a postdoctoral fellow back in 2008 to 2010. I joined the team. We did a randomized controlled trial of the Strength at Home Veterans Program compared to an enhanced treatment as usual waitlist condition. We enrolled a sample of 135 veterans, and results showed that in comparison to that waitlist control condition, Strength at Home veterans resulted in greater reductions in the use of physical and psychological aggression towards partners. And that's what that looks like. So you can see that at baseline, the two conditions were relatively similar in their reported use of aggression, physical aggression in relationships. The blue bar here is that waitlist control condition, and the yellow is the Strength at Home condition. You can see that by post-treatment, both groups have reduced their aggression, which is a good thing. And that significant difference is there between the waitlist control condition and the Strength at Home condition, which carries over into the 3-month follow-up. One quick note about aggression, and one of the reasons it's so hard to study and develop treatments, is that just monitoring someone's use of aggression in relationships results in decreases. So just by enrolling in our program, people were more likely to reduce their aggression because they were enrolled in a program, they were interested in it, and then it was being tracked over time. And these numbers reflect both the veterans' reported use of aggression and their partner's use of aggression. And the way that we do this in our research studies is that we measure the same period of time, and whichever member of a couple reports the greater amount of aggression, we enter that into our models. And by the way, partners tend to report more aggression than, veterans tend to report more aggression than partners. That's a common criticism that we might get, that we get from reviewers, is that the persons enrolled in your programs may be more likely to sort of have a bias towards saying that it worked, but actually they report more aggression when you compare those numbers to their partners' reports. We saw the same pattern of results when we measured psychological IPV. So here the red line is our Strength at Home group, the white line is our enhanced treatment as usual group. And you see that they start off about the same, and you see greater reductions in the Strength at Home group in that red line. Again, this is psychological aggression. We did a follow-up study where we looked at changes in, I told you that our comparison condition was an enhanced treatment as usual waitlist control. Well, at the end of the study, we offered them the treatment. And so in this study, the results that you're looking at here, we examined whether or not the program was just as effective if someone waited 6 months to receive treatment. And what these results showed is that we still had a positive result on physical IPV. We also measured alexithymia, which many of you are probably familiar with, which is that sort of difficulty kind of naming and feeling emotions. And so the program appears to have an effect on that compared to the waitlist group. Why is that? Well, we do really heavily have a focus on identifying and understanding emotions. And so we think that that's kind of a driver of this effect. When this trial was finished, We were lucky enough that this work happened to occur at the same time that the VA was recognizing IPV was a significant problem in our population. And the VA had convened this domestic violence task force to begin to develop recommendations for a national program. That task force ended up really coming up with a comprehensive list of 14 recommendations, like screening and prevention recommendations, employee assistance, and really emphasized and was a real leader in this area. It had really never been done before in a healthcare system. And so the program specified that the comprehensive transformation should be holistic, it should be veteran-centered, it should have a psychosocial rehab focus. And lucky for us, recommendation 8 happened to be that the VA should pilot a promising veteran-specific intervention for those who use aggression in their relationships. And we were one of the interventions that they had noted was a pilot at that time. And so that provided us with a lot more resources and support to take what we had learned in our RCT and then implement it into typical clinical care. And so the first year that we tried to do this, we called it our pilot rollout. We received some extra funding by a foundation to offer a training to 79 staff at 10 hospitals. We model a lot of our implementation on that of cognitive processing therapy. We even went to Cincinnati, spent a week training with Kate Chard, watching her train others in CPT to really learn how do you train people in an intervention. At that time, what we had designed was a model that clinicians received in-person training from 3 trainers. And so that's me in the middle. And so we would go to the sites and provide a 2-day training. Clinicians would receive a telephone orientation. They would receive monthly consultation on implementing the program as well as clinical consultation. And then they would get phone and email support. That was our first out the door attempt to do this. And we required clinicians to attend the training, to complete 2 groups, to attend their calls and to return program evaluation materials, and then they could be a program graduate. Well, we studied these materials that they returned, and the first thing we looked at was whether the program was effective when it was implemented by clinicians at these, theoretically at these 10 hospitals. And so what we showed is similar to what you saw in the RCT. So this is showing you the change in the number of types of IPV that a veteran indicated they used before treatment to after treatment. And the types of IPV we're talking about are physical, psychological, sexual, and coercive control behaviors. So there's a max of 4 that we measured. And so you see that they started with a mean of reporting about 1.5 types, and we saw a significant decrease in the types of aggression they used with a medium effect size. And when we drilled down into the very specific types of IPV, like physical, psychological, or coercive control behaviors, we saw significant reductions in the proportion of veterans with self or partner reported use of aggression from before treatment to after treatment. So that was really good. That meant that it looked like our clinicians had learned to deliver the program, and it seemed to be working at these first pilot hospitals. We also saw a significant reduction in PTSD symptoms with a medium effect size. So again, that was really good. And it shows that, in many ways, improving relationships has an effect on PTSD. Or it's picking up on sort of the relationship distress aspects of PTSD as another way of looking at that. However, when we looked at our clinician and our hospital adoption rates, these were not great. So 1 year after receiving that 2-day in-person training, only 70% of our hospitals had started a group, and only 34% of the clinicians trained had facilitated at least one group. which is not great in terms of learning a new treatment modality and retaining that information. And only 6 of the 77 clinicians we trained had completed all their requirements to be a program graduate. So that meant that we needed to make some changes. So some of what we introduced are what you see present now. There's an application process that's required to receive the training, and leadership has to sign off on that. And so if you're at VA, you know that clinicians, this program tends to be implemented through the social work service. And so there's, at most hospitals, there's an intimate partner violence assistance program leader and other clinicians. And so clinicians that want to receive the training, they have to have their application signed off by their service chief. And then if the IPV assistance program coordinator wants to become a new site, well, that person has to get their application signed off by a member of the quadrad. And the reason that we did this is because we realized that we were losing leadership support, or we never had it to begin with. And you really need that to introduce a new program at VA. We also started enhancing a pre-training orientation to make sure that people knew everything they need to know about the program before they received the training. And we created some other materials to help people initiate the program. And one of the reasons this is important, something that we learned, is introducing a new treatment for IPV is not like introducing a new therapy for PTSD, right? If you had a new treatment for PTSD, there's already an existing path forward for you in that people know how they would write notes for that. They know how they would bill for that. But for IPV, this is completely new. There were no note templates available. There was people had tons of questions about how they would bill and diagnose and so on and so forth. And so there was a lot of on the ground kind of implementation support that was needed that we learned over time. And so in years 2 and 3, with these changes, we saw that they significantly improved our hospital time to adoption. And so this shows you the mean number of days between someone receiving the training and that hospital having their first group session of Strength at Home. So in the first year, it was 135 days, but once we initiated these changes, by year 2, it was a mean of 66 days, and year 3, it was 77 days. And that was a significant decrease in time to adoption. And when we looked at the number of clinicians who adopted the program, as evidenced by offering a group within 6 months of training, we classified them as adopters if they offered a group within 6 months, late adopters if they offered it between 6 and 12 months, and never adopters if they never offered a group but received the training. And so you see a significant increase in those adoption rates from year 1. If you look at adopters in 6 months from year 1, 2, and 3. And so that's that first row where we go from 14 adopters to 28 to 35. So again, we significantly increased our percentages of clinicians who were able to offer the program. And so here we are today, which is that we've, or this is our September update. These numbers change all the time. So we've trained somewhere over 140 VA hospitals, over 1,200 clinicians. We've also adopted a regional trainer model so that we realized after year 3, we started really scaling exponentially. And so it's one thing to go and travel to 10 hospitals in 1 year. It's another to the next year travel to 30 and 40. And so we needed others to help us go forward and train. And many of our facilities have adopted some really innovative delivery models, like in Vision 1, they do these inter-facility consults. So, New Hampshire may not be able to offer a group because they didn't get enough referrals, but if they partner with Boston or Rhode Island, they might be able to all form a group together. So it's been really great to see some of the innovations that have come from the field to meet veterans' needs. And now I want to show you some of our 6-year results from all of these hospitals. One thing I want to note is that clinicians who are in the training program, they provide program evaluation information to us for 2 groups. And then they don't have to do it anymore. And so this is just a small sample of the veterans who have received the program. This is only veterans who received the program from a clinician in the training program, if that makes sense. Clinicians who are no longer in the training program because they're graduates, they don't provide this information to us anymore. So that's where these numbers come from. But you can see that it's over 1,900 veterans with information for us. Many were justice involved through veterans courts, average age of 50. You can see our diversity breakdown here in terms of the race and ethnicity of the veterans enrolled in our program. This is all self-report. You can see the service era, and we have had some many older adults come into the program as well. It's not just those who deployed to OAF, OEF, or OND. And what you'll see here in terms of the results is that they look remarkably similar to what you saw before. So even at scale, in this large sample size, we see significant decreases in the number of types of IPV from pre to post treatment with a medium effect size. The same pattern, if we look at the specific types like physical, psychological, or coercive control, we see significant decreases in the proportion of veterans who report they're using these types of aggression before treatment to after treatment. We see significant decreases in PTSD. This is with a small effect size. Significant decreases in alcohol misuse. And we've moved on to test the program in other settings. So we did a trial at Joint-Base Lewis McChord, again, showing the same pattern of results, which is that those who received the Strength at Home program, this was our couples program, evidenced greater reductions in all of the types of IPV that we measure. And they also importantly had reductions in suicidal ideation when they received Strength at Home relative to a control program. We have done a pilot study in a small sample of men who were court mandated to treatment in an urban setting. This was a very low income group who had a history of really severe physical IPV use. And we saw significant results in this group as well, with moderate to large effect sizes. And then we've gone on to extend this work to related problems like parenting. And so I want to tell you just a little bit about that work today, and that's where I'll end us. So we talked a lot earlier about the association between PTSD with IPV, but it's also associated with parenting problems. And so some of the parallels make Strength at Home an ideal starting place to introduce a parenting program at VA. So PTSD symptoms, higher levels of PTSD seem to be associated with the other behaviors in parenting, like inconsistent discipline, harsh parenting practices, and unfortunately, there's a very strong, robust association between PTSD with physical aggression and child maltreatment towards physical aggression towards children and child maltreatment. And on the other hand, children of a parent with PTSD are at increased lifetime risk for psychosocial and psychiatric problems. And one of the modifiable factors there is parenting. In addition, children who are living in homes where parents are using IPV have these same sort of increased risk for psychosocial problems, increased risk for maltreatment, and parents who use IPV also have a higher likelihood of using some of these parenting practices that we're talking about that are concerning. And so we thought, given all of that, and our level of implementation at VA, that's a great starting place to try and see, can we adapt this to the problem of PTSD and parenting difficulties? And so currently at VA, if you want to address this issue, there's not a lot available. So there's a couple of online resources. There is some implementation of a version of STARE for parenting. I don't know a lot about that because it hasn't been published about, but I know that that is available in some places for women veterans who are participating in STARE. But there's really not a lot nationally. And so we undertook a program of research to see if we could develop something. And so what we came out with was Strength at Home Parents. It's 8 sessions long. It's intentionally accessible. And what I mean by that is only one parent attends. So it doesn't require both. If there are 2 parents, it doesn't require both of them to attend. It doesn't require the child to attend. The clinicians who have been trained in Strength at Home are going to be familiar with the format and many of the skills of the program. Similar to Strength at Home, it's kept at a basic skill level. So veterans don't come in and learn something new every single week or 20 new things every week. They learn a few core evidence-based skills that are repeated over and over. And that's something that's present in all of the Strength at Home programs. It's designed for veterans with PTSD and parenting problems. And we went, while we were working to develop this, we received funding for this initial work to do a pilot trial where veterans would give feedback on the program, and we would have an expert panel give feedback on the program. And then once we felt that it didn't need to be adapted any further, we did an open trial for evidence that it was effective. And an open trial is just kind of a pre-post outcome study where there's no control group. And so this is what Strength at Home Parents looks like now. You'll see that we talk about child development and attachment and the ways that trauma can interfere with attachment. We talk about reactions to stress and trauma. We talk about emotions, consistent discipline. We do positive family and communication skills training. We talk about screen time and family safety. That's where we begin to talk about IPV. We do a family stressors and family safety, and so on. And here's a few of what the skills look like. So this is some of our positive discipline and timeout materials. And so I just wanted to highlight that something that we found really effective that we ended up using again and again was to put up this picture of a brain and to talk about the areas of the brain that seem to be working when someone is in fight or flight and when they're not, right? And so we make the connection between parents' fight or flight and PTSD symptoms with children's experiences when a parent is yelling, hitting, or isolating them, and how that interferes with their learning of the things that they want them to do. Like if you want your child to learn to pick up Legos after they use them, then yelling and hitting is probably not the way to support their learning, right? Because they can't, because that part of their brain is turned off. And so that's been a really effective way, and veterans really like that. They can really latch on to that. And so we've ended up using that again and again. And similar, you see here, we talk about positive discipline, that consequences should be related, respectful, reasonable, and revealed. You know, this is to combat against things like sometimes an example of this is someone will say, well, they didn't pick up their Legos again, and so I told them we will not be going to Disney World this year. Well, that's not going to work, because that's not something that's related to picking up Legos, right? So that's what some of the materials look like. We do a gun safety session, which we're really proud of. And actually, Jeremy really helped put this together. When we started this work, people kind of wanted us to shy away from it, but we just felt very strongly that we couldn't do this work without doing a gun safety session. It goes really well. Many times the veterans report that they're already using these strategies, but sometimes they'll say, yeah, I could probably get back to that. It would be helpful to revisit that. So it's not something we shy away from whatsoever. We did a pilot trial in a sample of veterans who had a child between 3 and 12, PTSD, and parent-child functioning difficulties. And all of our outcome measures went in the expected direction, which is that we saw improvements in family functioning, decreases in harsh discipline, reductions in parenting stress, increases in positive parenting. And the veterans really liked the program. And then we went on to do a larger open trial, and this shows you the pre to post treatment means for all of our outcome measures like family functioning, child and parenting stress, PTSD, depression. We saw significant decreases in all of these variables. And then moreover, I like to put this in the words of the veterans who participated in the program. And this is some of the quotes that they gave us at the end when we had an open-ended response. Things like, I'm going to lead a different life. I've thought about having another child for the first time. Some of them talked about their relationship is stronger, their child is happier and healthier. It's alleviated their stress, so on and so forth. The group is a powerful place for veterans to connect with one another about this issue, to see that they're not alone in struggling with these issues. Some of these sessions are quite emotional. And in conclusion, I'd like to bring us back to where we started, which is that IPV is a serious, it's prevalent and costly problem. It's traditionally been highly stigmatized, addressed within the justice system. And our work within VA shows that addressing it as part of healthcare was successful. We can do this type of really hard work. We would love to see it extended to other types of organized healthcare system. Our parenting intervention is a promising intervention that we hope to be able to study further. And we also have beat the odds of those statistics that we started with, that it takes 17 years to implement and only 14% of interventions reach clinical care. We have done this work in about 10 years, and now we're at every hospital. So this is my email address. I'd love to hear from you. We also have a website that you can take a look at. We have a YouTube channel. But I will leave that there for a moment, and I'll see. Yeah, okay, Edgar's reminding us to type any questions into the Q&A. I would love to hear those.
You know, while we're waiting for some of these questions to come up, you know, Suzannah, I just want to thank you so much for all the work you're doing and presenting. I know it's impacting a lot of people, and I bet a lot of these providers, if not the people who haven't heard about it, are very excited about everything that you're rolling out.
Well, thank you. It's, you know, I would say that it's some of the most rewarding work that I've ever had a chance to do in working with persons using aggression, and now in our parenting groups. They're, although these issues are really heavy and they're really hard, the groups are fun, they're lively, people make such significant changes in their lives, and it's one of the places where you really get a chance to see it when you work in family functioning. So it's just been such an honor to get to do this work.
Looks like you may have done, oh, there we go. So the question is, thank you for the presentation. How have you all handled needed mental health referrals when you contact the person affected by the violence?
Yeah, that's a great question, because that's been a hard issue. It was harder earlier than now. So, you know, early on when we started our implementation at each site, we asked them to find out what's available locally if someone needs a referral. And so we helped them develop the types of referrals that they needed. And we also encouraged them, okay, now vet them, like actually pick up the phone and call them and make sure that they exist and what would happen if you made a referral, etc. So we coached people through that process to find those local referrals. Now with the intimate partner violence assistance program coordinator that's at every hospital by law, those coordinators are in touch with the community much more. It's kind of built into the program to be able to refer someone, and they can also see people affected by violence who are not veterans.
And y'all, okay, so you have another one. This has been great. It's a lovely example of how to create an EBT in an area that has lacked evidence-based interventions and how to extend it into other populations. Congratulations.
Thank you.
From Brian Mai. I think that was more of a congratulations than a questions, yeah. But definitely appreciate it.
Yeah.
You know, I'm wondering, as we're kind of waiting for any other potential questions to pop up, you know, in Strength at Home parenting, I know that very similar to Strength at Home, for interpersonal violence, you talk about, you know, emotion regulation. I think with parenting, there's that cultural component about, you know, where does this happen? What do you notice with parents as they start to talk about those cultural messages, whether it be military, gender related, family related, and kind of, you know, what they realize as moving forward with that?
Well, I think that, you know, through those sessions and the conversation that they have with each other, they start to recognize that sort of the messages that they received were drivers of some of the distress that they were experiencing now, potentially drivers of aggression. And so they sort of were recognizing, like, I want to be open to my own emotional experience, and I want to foster that in my children, but I don't know how. And so working towards this acceptance of, like, emotions are okay. It's okay to have them. It's okay to have them now in this group. It's okay to have them at home. It's okay to have your child, like, children cry, they get angry, and that's good. That's healthy. And so really fostering that, and sort of, you know, for many, not everyone, they begin to develop that acceptance of those different forms of emotion that aren't just anger. And that's, you know, that's hard to measure. But I think that's definitely something that we do see. And it's some of the most, like, poignant session material that we see in group. When I see a question about, is this appropriate for only verbally abusive behavior? So the Strength at Home Veterans program that is now at almost every VA hospital is appropriate for veterans who are using physical, psychological, verbal aggression towards a partner, or those who are just interested in improving their relationship. So it spans the spectrum of interest to definite use, right? And in our parenting program, it is for veterans with PTSD and parent-child functioning problems. So we don't really define the type of problem it has to be, because we want it to be accessible to as many parents as possible who are having difficulty parenting, whether it's stress and just interest in improving their parenting, to some of those more harsh behaviors.
Well, Suzannah, thank you so much for all your time. We're right on the hour. I know that you're going to do amazing work moving forward, so I definitely look forward to hearing about it. And I'm sure a lot of folks feel the same.
Thanks so much for having me.
Yeah, of course. Before we close out, we just have a couple of announcements. And Edgar, did you want to take those?
If you want to let people know about the incoming webinars, and I'll let people know of the VA section meeting that's coming up here this month.
Sure, not a problem. So in next month on the 6th, which is a Monday, at 12 p.m., we have Dr. Marin Beagley, who is going to be presenting on adherence to traditional masculine gender role norms as a risk factor for non-suicidal self-injury in veterans. Currently, we're waiting on the CE approval for that. So as soon as it comes out, we'll be distributing the flyer and marketing for that a little bit more. And that's it for March. Edgar, I'm sorry. And we also have Dr. Melinda Trujillo on March 1st doing a presentation on Latinx psychology. And we are waiting for the seat on that. So as soon as we have all of that, we will send out the flyers. And Edgar is very wonderful about marketing this for us, as well as the other committees.
Yeah, thanks, Jeremy. Just wanted to give our members and non-members, if you want to become a member, a quick update that on January 19th, we're going to have our quarterly VA section membership meeting. We're going to talk about VA Psychology Recognition Week. We're going to talk about our coming VA Psychology Leadership Conference, APA Convention. We're also going to be giving you all some exciting updates in terms of the VA section committee action plans and what to look forward to over the next year or two of what we're going to be trying to do for our members. So lots in store for you all. Please, those meetings is going to be the 19th, which is a Thursday at 3 p.m. Eastern. You should already have a calendar invite on your calendar if you're a member. So look forward to seeing you there. And again, as always, thank you all for supporting our monthly webinar series. We'll see you again next month. Take care.